EGFR rechallenge or recycling of EGFR inhibitors or reusing it after prior progression, we clinically do this all the time. Patients may get a biologic in terms of anti-EGFR added to first line or second line therapy. They may go on to some of these salvage drugs in terms of regorafenib or TAS-102. And then because of many of these patients, we know there is rise of young onset colorectal cancer. A lot of these individuals in their 20s, 30s, 40s who are getting diagnosed with advanced metastatic cancers, they go through multiple lines of therapy. And then the question often comes up is, if we don't have a trial, what do we re-challenge them with? And EGFR re-challenge is often a question that comes up on a day-to-day practice. The issue is there are numerous studies to show where post-EGFR exposure, these tumors are not RAS-RAF wild type anymore. We know from multiple studies, both done in tissue sequencing, where if any of these acquired baseline mechanisms of resistance are present, then these anti-EGFR therapies don't work. Now, downstream, when you've used all these options, and now you're re-challenging the patient, you cannot rely on a biopsy from 3, 4, 5 years ago. In that situation, if you did a tissue biopsy, that also would not necessarily give you the whole picture in terms of, we know there is both intratumoral as well as temporal heterogeneity. In terms of doing a liquid biopsy in these patients, we were able to show that these tumors do not remain RAS-RAF wild type anymore. There is elegant work from our colleagues at MD Anderson where they've shown that a lot of these mechanisms of resistance that are present are in the EGFR RAS-RAF pathway, and could range from subclonal RAS mutations, RAF mutations, PIK3CA, HER2, EGFR, ectodermal mutations. And if they're present, those are the patients where you don't want to challenge them with the drug that likely will not work. And where do we come from to that conclusion is actually right now 3 different trials that have been published and presented. 2 of them were earlier at ASCO as ESMO, the so-called CRICKET study, which is already published in JAMA Oncology, which was cetuximab re-challenge. And again, this was a prospective study, but they looked at the liquid biopsy retrospectively. And what they found was if you had any of these mechanisms of resistance, again, they were trying to see if you were now liquid RAS-RAF wild type. If you were, then you derived benefit. But if you had any of these aberrations, you did not derive. Another study, which was CAVE, again, this was cetuximab with avelumab re-challenge. And again, patients who had previously failed anti-EGFR therapy, similar conclusions. Again, minimal benefit whatsoever in terms of if you had any of these mechanisms of resistance. And if you did not have them, those were the patients who had a longer PFS as well as overall survival. And recently, these findings were again replicated from a Japanese cohort of the Pashtoon M cetuximab re-challenge, where they came to the similar conclusions. What we were able to show within our case series was that for sure these tumors do not remain RAS-RAF wild type after you have exposed them to anti-EGFR and after they progress through it. But B, building upon the work from MD Anderson, where they had estimated the half-life of some of these clones, if you don't challenge them with anti-EGFR and do something different, whether it's a TKI, salvage therapy drug, or anti-VEGF or a trial, down the line, these patients can lose these mechanisms of resistance. Cancer cells are efficient simplistically, so they often would not necessarily acquire mechanisms that are no longer needed. And then in those patients, if you re-challenge them, we were able to drive and benefit and show the value of serial testing in this particular situation. This is one area, again, we're talking about NGS-based, circulating tumor DNA-based testing platforms that anti-EGFR re-challenge at least should be avoided in patients who have any of these mechanisms of resistance on any of the liquid biopsy platforms. And if they are absent, I think those are the patients where you consider the challenge and spare the toxicity in the ones who truly have mechanism of resistance. Another advantage is that HER2 is an acquired mechanism of resistance, again, to anti-EGFR based therapies. A lot of these RAS-RAF wild type tumors, they acquire HER2 down the line. as one alternative pathway of exiting in terms of EGFR sensitivity. And for those patients, we have been privy to multiple HER2-based therapies, which was one of the key outcomes of ASCO GI this year and last year. If there's one target for which there are so many drugs coming out, whether these are TKIs like tucatinib or some of these antibody drug conjugates or other anti-HER2-based therapies, the key issue is, how do you find these patients who are HER2 positive now truly in an acquired setting? If you look at baseline HER2 expression, that's less than 2% in patients with colorectal cancers and often seen with rectal cancers. But post anti-EGFR challenge, these numbers can go up to anywhere from 15-25%, depending on the different series that are published, where a non-invasive way of finding these patients would be through liquid biopsies, i.e. a circulating tumor DNA-based testing platform, which is NGS-based. And that builds upon the existing work from several prospectively done trials for which samples were retrospectively analyzed, and an increasing body of literature and case series where, from a clinical standpoint, we do this all the time, but we could be more smart about sparing the toxicity from anti-EGFR therapies to the ones who have resistant mechanisms of anti-EGFR versus doing it in patients who don't have this, and i.e. their liquid biopsy RAS-RAF wild type.